Mesdames et messieurs, bonsoir.
Ladies and gentlemen, good evening. It's a pleasure to welcome you today for our Procure en Parle series. This is our fifth webinar of this series. Information, as we say, is our first line of defense, and this is why we're so glad to host this webinar. Did you know that in many cases it is not necessary to treat prostate cancer? How do we then monitor it, and how should we know whether we're a good candidate for this option? Is this approach safe? All these questions are why we're going to look into active monitoring as a treatment option. We're going to discuss this with Simon Ouellet, urologist at the Rimouski-Bassin-Laurent Hospital. He completed a fellow for a specialized training in oncology and urology in Vancouver. There will be a keynote speech, and then we will move on to questions. And thank you to those who have submitted their questions ahead of time. Otherwise, you may ask your question now using the Q&A feature at the bottom of the screen. I would like to thank all of our donors, of course, as well as our official partner, Industrial Alliance, as well as Astellas, and the Canadian Urological Association, as well as the Quebec Urological Association. Procure is not only a member of the Canadian Urological Association, but also recognized as its official partner throughout Canada related to prostate and testicular cancer, and this is great news. So thank you, Dr. Ouellet, for accepting the invitation. And without further ado, please go ahead, you have the floor. All right, thank you so much. Thank you for inviting me. I'm wearing the Procure tie knot, which is a way to encourage the organization. This was offered by one of my patients. So yes, we'll talk tonight about active monitoring. It could seem counterintuitive, but indeed, prostate cancers, in some cases, are to be managed in this way. We'll briefly cover screening of prostate cancer. This is, of course, the first step for the diagnosis. Will be fairly brief, and then we'll focus on active monitoring per se. So we're going to look at who are the best candidates for this, the role of PSA, and what we can do to limit the likelihood of cancer progression. We'll try to save some time for questions as well. So quickly, talking about screening. Screening is to have an early diagnosis as much as possible, because we want, of course, to screen before we get to a metastatic stage. Of course, there's a better rate of success and survival with early diagnosis. What we use is digital rectal examination, and we also use some blood work for dosing PSA. So we combine the two. PSA is a great predictor. It's prostate specific. It's secreted by the prostate. Nothing else in the body will secrete PSA. It's absent in women. However, anything that will disturb the prostate will see the PSA increase. So when we carry out screening, we need to make sure that there is no infection or nothing else that it will influence the result. So this is good because when PSA is under 1, the risk of cancer is so low that we can wait 4 years before another checkup. If the score is between 2 and 3, we can do 2 years. And when it's above 3, Then we can have PSA checkups more frequently, and depending on PSA level trends over time, age, of course, and other elements, then we can say, okay, should we move to an MRI or a clinical monitoring? After 70, in most cases, we stop screening. There isn't really a benefit for these screening procedures, since prostate cancer is a slow cancer. So at 70, if you don't have a prostate cancer yet, there is very low risk that this will be a problem. Also, if longevity is deemed less than 10 years, same reason, there is not really a benefit to diagnosing cancer, because even if there is a prostate cancer, it will not lead to death. Most of you, if you're here, you already have a diagnosis. So you've had a biopsy. This is what it means. So following PSA and digital rectal exam, if there's an anomaly, then we move to a biopsy. This is the most common procedure. We measure a few things, including prostate volume, and then we move to the biopsy. This is a good technique. There is, however, a risk of infection. It's not very frequent, but still, it's something that needs to be taken into account. But again, today, this is the only way to diagnose prostate cancer. We can have a good idea of the likelihood depending on the MRI and PSA levels, but the confirmation is done with the sample. This also helps us to see how aggressive the cancer is. An MRI is also a good tool. It can give us an idea of the risk, whether the risk of cancer is low or high. We'll get back to that momentarily. Dr. Ouellet, could you share your screen actually, please? Thank you. Oh, apologies. Yes. Are we good now? Yes, we are. Thank you. So, prostate biopsy. As we were saying, let me just... okay, there we go. You can see the screen, right? Okay. So we're talking about investigations, whether through a biopsy or MRI. So why a biopsy? Well, as you can see on the right, we use a specific tool. The prostate rests on the rectum, so we can sample the prostate this way. This helps us to answer two questions. Is there cancer? Yes or no? Like I said, it's not extremely precise. We can miss 20 to 30% of cancers this way, but it gives us a good idea. But especially, how aggressive is the cancer? This is the main question here to help us see if people are good candidates for active monitoring or for treatment. We can have also some testing before the biopsy. So if we use an MRI before the biopsy, then we can have a better idea. If we see any spots with the MRI, for instance, then we can know where to sample the prostate. If also there is a waiting time for an MRI, then we can just skip that step and go straight to the biopsy. Now, not all men who have cancer will require treatment. About a third of men diagnosed with prostate cancer are advised to simply continue with active monitoring. This is the Gleason Score. You've probably all heard of it. The Gleason Score is the information coming from the pathologist in order to assess the aggressivity of the cancer. it's a little difficult, to understand why does it start at 6 or 10. It may seem illogical, but this is how we calculate things. We use a grade now, so 1 to 5. So if the grade is 1, it corresponds to a score of 6. If the grade is 2, it means that the grade and score is 3 plus 4 equals 7. So an intermediate risk. If the grade plus score is 4 plus 3, then there's a higher risk. So anyway, all that to say, we spread those out into these grades from 1 to 5. When we are at grade 5, then, whether the Gleason score is 9 or 10, it's pretty much the same. The risk is deemed very high. The highest number corresponds to more cells resembling cancer cells versus normal ones. There can be other tests that can be carried out. If we suspect that the cancer could have reached the nodes, lymph nodes, or other organs, this is where we use these additional tests. So it can be an abdominal scan to see if the disease has reached other parts of the body. We also have a bone scan that can be appropriate. And again, MRI. If your cancer does not require active treatment, then the likelihood of the cancer spreading is next to 0. So if you're under active monitoring, then it's unlikely that these tests will be carried out. However, there is an interest in some of these tests for active monitoring later on. Now, why an MRI? I already mentioned we could do that before a first biopsy. What we see in Quebec, however, is typically a biopsy first. If there is cancer requiring treatment, then we move straight to treatment. If the cancer is at an intermediate stage, then an MRI can be used. The idea is to see if there are zones that are concerning. We can identify the suspicious zones, and then we carry out a second biopsy to make sure that we haven't missed a more aggressive cancer. And we can use the MRI to know where to sample exactly. So, if the cancer is not visible with an MRI, this is good news. Typically, then you are a good candidate for active monitoring. And again, it's not because we observe something with an MRI that it's cause for concern necessarily. Typically, we'll simply want to sample the zone to see, is there something more aggressive that we've missed? And with this MRI, we can be pretty confident that active surveillance is the way to go. An MRI can also be carried out as part of a treatment to say how much the cancer spread locally. So is it reaching other nearby organs? So these will all help, for instance, in watching out for the seminal vesicles. Radio-oncologists use it before a radiotherapy, and to assess the effectiveness of a treatment, we typically use PSA dosing, but in some cases we can use an MRI as well. The MRI score, this is very different from what we get through a biopsy, to be clear. So, typically, there is some level of correlation. So if there is a very low aggressiveness detected one way, then the MRI will likely reflect that. But still, it gives us a better idea. So when the radiologist reads through, if there are no finds, then great. The more the prostate is large, also, the more we'll want to look into this. So typically, if the PI-RADS score is at 1 or 2, the risk is very low. So we consider that to be normal. This is good news and should probably lead us to active monitoring. If there is a find, however, this will fall under PI-RADS 3, 4, or 5. It will depend on the context, but at about 85%, there is no cancer at grade 3, and at grade 4, it's about a 50-50 chance of a clinically significant cancer. And with a PI-RADS score of 5, then we're at about 90% likelihood to have a clinically significant cancer. Most of the time, also the Gleason score will be higher as well. Now, moving on to TNM. You may have heard that. If you are at a T1, T2, T3 stage. So at T1, the prostate is deemed normal with a digital rectal exam. We could find some cancer cells without any other symptoms. At the T2 stage, there could be one small tumor. Then at the T3 stage, there is a level of invasion, so outside of the prostate. It can be T3A or B, T3B being a spread at the seminal vesicles. At the T4 stage, it means that the neighboring tissues are affected, such as the bladder or rectum. There's also N, which stands for nodes, lymph nodes, and M for metastasis. Of course, most people who choose active monitoring are at the T1 or maybe T2 stage. You may have heard about your risk group. So if your PSA is low, nothing at the digital rectum exam, then we'll recommend active monitoring. Very few of these people will see a cancer develop, a clinically significant cancer, that is. We may use an MRI to make sure that we didn't miss any other cancerous spot. But if everything else is at a lower risk, then monitoring is appropriate. Again, the progression risk that is deemed low is at T1. Then we move to intermediate risk. This is where we move from from one risk to another. then there is high and very high risk. If the PSA is between 10 and 20 or higher, as we said, then it is deemed at least an intermediate risk. The very high risk are going to spread over, for instance, the bladder or other neighboring tissues. This is the, again, progression risk fitting with each stage. So the likelihood of curing the disease is high, except with very high risk. So if there is local invasion, many patients can be cured. However, if cancer has reached the lymph nodes and it is at a metastatic stage, then it's a different story. If, again, a PSA is high, or if there is an anomaly with the digital rectal exam, then again we'll move to the biopsy. A negative outcome with the biopsy means that we'll move to active monitoring. But if the biopsy comes out positive, then we'll likely move to an MRI. We'll want to know, is the cancer clinically significant? Can it threaten the longevity of the patient? That's the first question. And if not, then we may want to move to active monitoring. Now, treating a localized cancer, so only in the prostate, nothing else, then in this case, typically we'll have an attitude of watchful waiting. We'll just make sure that there is no significant after effects or symptoms. For 1/3 of the patients, as I said, this is the way that we go. Otherwise, for treatment, there is surgery and radiation therapy. Now, how do we choose which treatment is appropriate? It depends on the age, health status, and it, of course, depends also on urinary function, erectile function. If you have a Gleason score of 6, say, most patients will fit with an active monitoring approach. If the risk is intermediate, then it will depend. It's an individual discussion to have. So this is the scheme that's been in use for many years, and we now have data for over 10 years that shows us that this is an appropriate approach. So active monitoring is for men with low-risk prostate cancer and some men with medium or intermediate risk. This is beneficial if we want to delay treatments, for instance. If the cancer is not very aggressive, we think, okay, the likelihood of dying from this cancer is very low, and we want to avoid side effects of the treatments, then we can simply apply active monitoring. There are also side effects with regards to urinary function and also erectile function. So the interest to delay treatment is to avoid these side effects and maintain quality of life. Of course, if there were no side effects to treatment, it would be pretty simple. We would simply treat everyone, and the vast majority of cases would be that the cancer would be cured. But because of side effects, of course, we want to look into that deeper. So the idea is to delay treatments if safe to avoid these side effects. For most people who go down the route of active monitoring will never actually get treatment. So what do we do when we are under active monitoring? And what is the process? Well, first, the factors to be assessed: the age. The older you are, the less time you have for the cancer to develop. So we'll be more comfortable with people aged 70 years or older, because statistically, also you have less years left to live. But if you're treated, then you suffer the side effects. So with a younger person, there's always this balance. We think, okay, well, there's more time to develop a cancer. But if we treat a younger man, then the side effects could stay with him for some decades. The PSA level is extremely important. The lower, the better. Typically, the line is drawn at 10, somewhere between 9.5 or 10.5. But the lower, the better. If PSA is at 10, then maybe there will be active monitoring, but the likelihood to be treated at some point in time is higher. As we were saying before, the Gleason score matters as well. If the Gleason score is at 6, then we may need a second biopsy to make sure that we haven't missed any more aggressive cancer cells. If the Gleason score is higher, then we will look into the options. Again, this is always discussed on an individual basis. So the biopsy results are extremely important. Ultimately, it's all a matter of managing treatment and its side effects, or no treatment. We want to make sure that people are comfortable with treatments. However, we also want patients to not feel anxious about active monitoring versus active treatment. There are many thousands of men who use this active monitoring method successfully. So here, observation or watchful waiting. This is especially for elderly patients. Some symptoms will be treated because the idea here is not to cure the cancer, because if life expectancy is low anyway, then it isn't useful to focus on curing the cancer. With active monitoring, we want to make sure that we have an opportunity to treat if necessary. And in this case, we want to cure the cancer. So with this watchful waiting, of course, we want to cure, or rather, watchful waiting is for just making sure that there are no large impacts. But the idea is not to cure versus active monitoring. The idea is to cure any clinically significant cancer. It will depend, again, on life expectancy. Typically, in older patients, there are other symptoms more concerning than the prostate cancer. So are you a candidate for active monitoring? Of course, this might be recommended if cancer isn't likely to grow and develop. Typically, the PSA level, again, will be 10 or lower. We just use 10 as a threshold. It doesn't mean if the PSA is higher that you're not a candidate. You could have a PSA a little higher than 10 and not get treatment for a while, or you could require treatment a year down the road. Again, with a Gleason score being low, then active monitoring may be recommended there. And especially also, of course, the tumor size will be factored in as well. And again, if the idea is to delay or avoid treatments, just to mention, someone who has perhaps an erectile function that is already null, then you have nothing to lose. But if the patient is sexually active, then it's something to be considered. During active monitoring, of course, we don't just say, okay, PSA is 8 and Gleason score is 6. Some people will require treatment. What we do is proceed to frequent blood checkups. There are also biopsies at regular intervals, and MRI can be used as well. And for some people, it's done as part of active monitoring. You can change your mind also at any time. Even if your cancer is not progressing, some people say, okay, I'm not comfortable with just monitoring and prefer to move to surgery or radiation therapy. This is always, of course, an option, especially in order to reduce anxiety. Our role is to teach people what the best course of action is and how to make a good decision. This is to show over here that many groups have done active monitoring. There are large patient groups that were followed up on for 15 years. So again, we know that this is a safe approach. Typically, we watch out for Gleason scores at 6 or 7, with PSAs around 10 or 15, and a couple of other factors. So what is the entry criteria for active monitoring? Again, if life expectancy is high, if the Gleason score is at 6, if PSA is low as well, if the prostate cancer is at a low volume, the tumor stage is low as well. If the Gleason score is at 7, then there's a longer discussion to be held, and we typically recommend an MRI. The reason is to make sure that we haven't missed anything. So in this case, most people believe it's better to carry out an MRI. If the MRI comes out negative, then we may sample a second time. If there is a spot at the MRI, then we'll use a biopsy to have a closer look. So this is where perhaps we can draw the line. In this case, the MRI is helpful for that. Now, exit criteria for active monitoring is, of course, kind of the opposite. Sometimes a cancer will be more aggressive than deemed initially, so this will typically occur in the first 1 to 2 years after having initiated active monitoring. In this case, we may then change tack and use treatment, and then we can still intervene early on. So typically for monitoring, we have PSA testing every 3 to 6 months, a digital rectal exam at least once a year. Sometimes we may use prostate biopsies or imaging tests. The biopsy is done initially for diagnosis purposes. Typically, I recommend an MRI after 6 months and then a second biopsy within a year of the first one. This is a confirmation biopsy. This is to make sure that we haven't missed an aggressive cancer. If we use an MRI, then we could be more effective in getting this confirmation. Then, if you have a cancer that fits with active monitoring, then we can use some tests every 3 to 5 years. And of course, it will depend on PSA levels. Of course, it's very important to do this follow-up. This is where we catch cancers that are growing and that will require treatment. So we need to accept that, yes, there will be consultations with a urologist and blood work on a regular basis. Typically, when people are well informed, this process goes smoothly. And typically, if we see that the cancer is developing, you still have a very high likelihood of getting it cured with treatment. You can see here various entities that have a similar approach. Just a few details that differ. Again, this is to show you, of course, that this topic has been well documented. And the approach of active monitoring, again, has been proven to be effective. So I'm just showing this very quickly. It's just to show you that there are several cohorts that have proven this approach to be absolutely reasonable. Now, with men who are younger than 60 years, again, there are two things. There's more time for the cancer to develop, but we have more to lose from treatment side effects. So if there are side effects, then they will be part of our lives for longer. So even if you're just 50, 55, if you're comfortable with the idea, you can be monitored. And of course, the younger you are, then the closer you'll be monitored, because you likely will require treatment at some point. Now, for trial study results, we see here a Johns Hopkins cohort of nearly 2,000 men, and the survival rate here was extremely close to 100%. Half were treated, but a quarter of them were simply by choice. So this is to show you that there is no negative consequence in initiating active monitoring instead of treatment if the right criteria are met. Here, we see that the treatment rates are at about 20 to 30%. If cancers are a bit more aggressive, or with a higher PSA, of course, then the treatment rate is higher. Progression risks. Again, this is a Toronto-based study that showed that after 15 years of monitoring, half of men were still not treated and under active monitoring. So, again, we mentioned this. The idea is to get the facts first, determine whether or not you're a candidate. Of course, we need to compare options. Is monitoring deemed a good option, or would you rather have surgery or radiation therapy? How do you perceive the potential side effects? All of this is to be accounted for. Generally speaking, for most men with a low-risk cancer, these side effects are concerning, and we delay treatment. I mentioned this earlier. So with the PSA, so PSA is a biomarker. If you have a relatively high PSA, it will indicate a few things, but of course it always depends. Of course, some people will die of causes other than their cancer. This is why we recommend physical activity, exercise. The more you exercise, the less likely your cancer will progress. But of course, we also want to focus on the cardiovascular side of things, which is a threat for most people. So exercise, again, is good for your cancer, but it's good for you globally. Statistically, we need to focus on the more pressing health issues. Cardiovascular disease is much more of a threat than prostate cancer as far as life expectancy and quality of life. Of course, eating well, is opting for a healthy diet is extremely important as well, not just for your cancer, but for your overall well-being. Now, about natural health products. These have not been demonstrated to cure cancer. The idea here is that a couple of supplements can help with your overall health, that is. In conclusion, only a biopsy can diagnose prostate cancer. The other tests will give us an idea of the aggressiveness of the cancer and help us see whether you're a good candidate for active monitoring or for treatment. Thank you very much. Now I'm willing to take on questions. I do thank you, Dr. Ouellet, for this presentation. Now we're moving on to questions. First question. 3 generations of prostate cancer in my family. I have just been diagnosed with a Gleason score of 6 at age 62. My urologist suggests active monitoring. I'm hesitating because of our family history. Should I get this cancer treated? This is a great question. Sometimes people are worried, indeed, if there are cases of prostate cancer in the family. Of course, there are several details to look at here. So if your father has prostate cancer, it about doubles your likelihood of also getting one. But if it is a low-risk cancer, having a family history does not mean that active monitoring fails. So in some patients, there are genetic mutations for specific genes that repair DNA. So we know that with these specific genes, there's a higher likelihood of a more aggressive cancer. So if these types of cancers are present, then yes, we could move straight to treatment. But what matters here is the characteristics of your specific cancer. So still, typically, we recommend active monitoring, even if you have a family history. Again, it's really your specific cancer that counts here. Second question. I am under active monitoring haven't for a year. I have a biopsy in 2 weeks. I did ask for an MRI before, and the urologist refused. However, in France, we have an MRI, then a biopsy. Why is it different here? Why, and what are the guidelines relating to biopsies? There are several reasons for that. Sometimes it's a matter of accessibility. It could take a year to get an MRI in some settings, so we don't want to delay for this reason. So it's preferred to get an MRI. I do it 6 months post-diagnosis. It allows us to better select candidates for active monitoring. It also allows us to, if there's a lesion, to have a very precise biopsy later on. So if at the second biopsy there is no clinically significant cancer, then we're pretty comfortable with just active monitoring. So yes, when the MRI is accessible, it is recommended. However, do know that an MRI is not an easy test to interpret for the physician. We have a question about a lady asking about her 55-year-old spouse. He got his third biopsy, and the question is, could these biopsies spread cancer to neighboring tissues? Well, so the risk of spreading cancer cells with biopsies is not really there. It's quite safe to sample and to carry out confirmation biopsies. The risk is essentially null. Now, how many biopsies can be done? Well, it will depend. Typically, we have a first biopsy initially, then one year later, and then every couple of years. So if it's been, 20 or 30 years, then yes, it can be several biopsies, but still, it's only every 3 to 5 years, and MRI can also help. In this case, it's been 3 years only. Okay. So if this was the third biopsy, so then probably the fourth one will be in a while. Okay. Is it possible to have an MRI result PRAD4 in one lobe and PRAD5 in the other, a positive digital rectal exam, a PSA at 29, and a Gleason score of 6? What does this all mean? My urologist advises me to move to surgery. I'm 59 years old. Okay. So with PIRAD-5, we need to make sure that the radiologist was skilled to read the MRI appropriately. We're talking about here at 85 to 90% of people who will develop a clinically significant cancer at a Gleason score of 7 or more. So in this case, there is a Gleason score of 6, but a high PSA. So most likely the Gleason score here has been under-assessed. So we probably have a somewhat aggressive cancer. Now the other question is, has the biopsy been done before the MRI or after? So we could have a biopsy of the PIRAD-5 zone, but anyway, with a PSA close to 30, treatment is definitely advised. Okay, another question. I received a diagnosis in 2022. I'm 55, Gleason score of 6, PSA at 4. My urologist gave me the choice between monitoring or surgery. I'm not a candidate for radiation therapy due to urinary issues. My bone scan is negative, but the MRI is positive, and there will be a targeted biopsy later on. If the biopsy has a score of 6, is monitoring an option? Okay, well, monitoring is an option. PSA is low, So this is good. The risk here is not about the Gleason score. The positive MRI will again, it depends if it's a PIRAD 3, 4, or 5. It's going to be a whole different story. If it's a PIRAD 5, it could be 85 to 90% likelihood of developing a clinically significant cancer. So, yes, active monitoring could still be an option. Most people, again, will be monitored long term. With the targeted biopsy, if there is aggressive cancer, then, of course, this needs to be discussed individually, and it depends also on the MRI. But yes, with a Gleason score of 6, even at high volume, we typically advise active monitoring. Okay, now a question from France. Hello, my spouse is 64 years old. He received a diagnosis. The MRI showed PIRAD 5 on the right and PIRAD 4 on the left. Biopsy, half of the samples were positive. The PSA is at 4. No trace of cancer outside of the prostate. According to the MRI, the Gleason score is at 7. But according to the biopsy, the score is 6. Is this possible? We're a bit confused. Okay, well, the MRI here. We can get a Gleason score with an MRI. The MRI is a picture, but it doesn't give us an analysis of whether a given spot is cancer or not. The only way to get a Gleason score is with a biopsy. However, perhaps we can think, okay, depending on the MRI, we would have expected a Gleason score of 7 or more, but your biopsy brings you back down to a score of 6. But this can only be determined with the biopsy. This is what gives us the aggressiveness of the cells under the microscope. This is why we use what we call merged biopsies. So this is the way to make sure that we have a good sampling of the concerning spots. Okay, could you explain the results of my MRI? I'm 64 under active monitoring. I don't need, in principle, treatment. The interpreter apologizes. The service will be back momentarily.
Comme biopsie jusqu'à maintenant, tu sais. Si vous avez eu
Okay,
une
this
première
will depend. So if you had a first biopsy or a confirmation biopsy later on, and if the PIRAD is at 3, then we may not have another biopsy. It depends, especially if you have a smaller prostate, then we think we'll probably have sampled throughout already. If there is a PIRAD lesion under the MRI, then we'll proceed to a biopsy. But if there has been a few biopsies, then it may not need to be repeated. But if, however, there are some finds under the MRI, then yes, we may move to getting a few other samples. Okay, so 1 or 2 more questions. So, hi, My score is 3 plus 3. I'd like to know what a perinerval invasion is. Does this mean I am not a good candidate for monitoring? Well, the short answer is no. Historically speaking, perinerval invasion is detected by the pathologist. There was actually a broadcast very recently in the US that shows that this has an impact on active monitoring. So the progression risk is probably higher, but you could still use active monitoring, but you're at a higher likelihood of requiring treatment at some point down the road. All right, last question. Could the levels depend from one or change from one lab to another? And can levels change during the day? Well, yes, they can change a little bit. We could have blood work every day and, there would be a little bit of a fluctuation. The idea is to look at a trend. Typically, what we recommend is to make sure that there is no infection, this kind of thing. All right. So we will need to wrap up at this point. Thank you very much, Dr. Ouellet. You were very clear. Thank you for awarding us your time. Any outstanding questions will be answered later this week. We want to thank the 270 participants that did fill out our survey. The results will be compiled by Léger and they will be broadcasted in September. Your participation is instrumental, of course, and your point of view is extremely important. Our next webinar will be on June 15. We will look at advanced prostate cancer and how to treat it. Our guest will be Dr. Paul Torin. So we'll see you there. Please don't forget that on June 19th, this is the date for the march in Quebec and in Montreal. Thank you, everyone.